All right, why don't we go ahead and get started. So just to remind everybody that we're going to have a little bit of a hiatus from Grand Rounds for July and August, and we'll come back together in September. The schedules for Grand Rounds for fall are out on the table with Stephanie, so feel free to grab those so you can get, not all the details are worked out yet, but at least the schedule is in place, so that's good. And I'm happy to answer questions about that if anyone has any at the end of the talk. It's my pleasure to introduce Sharon, who I've known for a long time now. Dr. Anderson received her MD from LSU, did her residency up at OHSU, and then did fellowship in nephrology at Beth Israel and research fellowship at Brigham and Women's and Harvard. She was on faculty there and then came to the Portland VA in 1991. I just wanted to give you some highlights from her CV just because it's fun to see all the things that she's done over the years. Her research interests include the progression of chronic kidney disease and diabetic nephropathy. She was funded for many years by the NIH, the VA, and other granting agencies and has over 150 publications. And the American Society of Nephrology has actually named a research fellowship in her honor. As an educator, she's won many teaching awards, including the Department of Medicine's Award for Career Achievement in Teaching and the Howard Lewis Award for Outstanding Teaching at the Oregon ACP. And administratively, she's been involved in a lot of national activities, being the first woman elected to the Council of the American Society of Nephrology and the first woman president of that organization. She has also served, I could go on and on about all she's done at OHSU, but she's kind of risen through the ranks there, served as the interim head for the Division of Nephrology and Hypertension, associate dean for faculty development and faculty affairs. In 2017, she was appointed dean of the School of Medicine at OHSU, so it's really an honor to have Dr. Anderson come here and speak to us today on Shall We Dialyze Grandma, the technological imperative versus the moral imperative. Thank you so much, Sharon.
Thank you. It's always a pleasure to come back here and see old friends. Some of the people in the audience, like Liz, I've known since she was an intern, but Steve Campbell pointed out he's known me since I was an intern, so we go way back. So I'm really pleased to be here to talk to you about a group of patients that all of us care for, which are older patients with kidney disease. I have nothing to disclose. So the population is aging, as you know. And with the aging of the population comes an increased incidence of diseases that are overexpressed in older folks, such as heart failure, dementia, and chronic kidney disease. This is data from the CDC. It's estimated that about 15% of the U.S. population has chronic kidney disease, but as you can see here, it's much higher in those over the age of 65. So there's lots of it, and it's imperative that we recognize it and know how to manage it. So I'm going to give this presentation with this patient in mind. This is an 84-year-old Caucasian woman with hypertension, diabetes, and atrial fib. Her medications are lisinopril, metoprolol, glipizide, and warfarin. Her blood pressure is as you see it. Her creatinine is 1.2, which calculates out to an estimated GFR of 45 mils per minute. That's been stable over the past few years, and she has no proteinuria. So what is the deal with the decreased renal function and aging? So this is a classic paper from 1950 by Davies and Schock, where they demonstrated that there is, in fact, an age-related decline in renal function. They used inulin clearance to measure GFR and diadras clearance to measure renal plasma flow, and showed that as patients go from the age of 20 to 80, there is a decline in both, albeit with substantial variability. At that time, they said a number of alternative hypotheses may be advanced, but we do not yet have the crucial data to decide what mechanisms are involved in the process. This is what's almost 70 years ago, and that's still somewhat true, but I would submit to you that a clue had been advanced a half a millennium ago by Dr. Thomas Sydenham, who said a man is as old as his arteries. So the aging kidney, the decline in renal function with aging is in fact, at least in part, due to increased disease of the small vessels in the kidney. And sometimes I think the kidneys are like the canary in the coal mine of the cardiovascular system. So In fact, there's a lot of evidence to support that. This is data from the Framingham study, which, as you know, was a big longitudinal study of how folks do over life. And they looked at the risk factors for having a high creatinine as you get older, or high creatinine period. And the risk factors looked for all the world, like classic cardiovascular risk factors, right? So you were more likely to have a high creatinine if you were older, if you had diabetes, if you have hypertension, if you're a smoker, and a little less of a risk if you have a high LDL level. So there's lots of epidemiologic evidence to sort of support that. And there are vascular changes that occur within the kidney. So the kidney is, I'll talk a little more about it in a minute, but I'll just point out to you that a couple things that have been recognized. So in the juxtamedullary region between the cortex and the medulla, what happens is you have a formation of direct channels between the afferent and efferent arterioles. The glomeruli just kind of disappear. So you have these aglomerular arterioles, which actually aren't very functional in terms of filtering. And then in the cortex, you're more likely to have atrophy of both the afferent and efferent arterioles, and you get global sclerosis. So glomeruli just sort of die off, and they're not very useful either. And there's also, with aging, an increase in the interstitial volume. So this is from an autopsy study looking at how much of the cortex was interstitial fibrosis, basically from younger age to older age. And we know that there's an increased amount of tubular interstitial fibrosis in the aging kidney, and that correlates well with loss of function. So what is the prognosis for our patients? So we're learning a lot about how to individualize patients in this era of precision medicine or personalized medicine. So let me contrast these two patients. So my patient is an 84-year-old Caucasian woman with a GFR of 45, and in contrast to that is a 35-year-old African-American male with a GFR of 45. So the renal prognosis for these two individuals is very different for three reasons. One is age. The older patient sort of has a shorter time horizon to lose more kidney function. One of them is gender. Women are slightly protected. It's pretty weak, but there may be a slight female gender protection. But there's definitely an ethnicity factor here in that African Americans, as compared to Caucasians, are equally likely to get chronic kidney disease, but once they have it, they're far more likely to progress to end-stage renal disease. And in many cases, that's associated with expression of a specific abnormal ApoL1 genotype. So prognosis is very different. And this was a really interesting study, I thought, that it asked the question, let's say you have chronic kidney disease and you're losing GFR over time. At what point does it become inevitable that you're going to have to go on dialysis, or you're very likely to go on dialysis? And that actually is a function of age. So age groups go from left to right, 18 to 44 on the left, 85 to 100 on the right. And it turns out that if you are at a younger age group, the number is 45. Once your GFR declines to 45, there's a pretty good chance you're going to go on dialysis. In contrast to older people, the very advanced age groups, it's more like 15, right? So, or put another way, if your GFR is above 15, chances are you will pass away, hopefully, peacefully without it. So the prognosis at a GFR of 45 is very different in my two patients. So what is her prognosis? This is kind of a cool tool. So this is from an app called QXMD. You can download it. It's for free. I have no connection with this company, no financial interest. But it's useful for sort of giving you predictive equations. So I've got this, I'm sitting there in clinic with my 84-year-old woman, and what can I hypothesize about her renal prognosis? So this actually has a kidney failure risk equation to determine the 2 and 5 year probability of going on to need dialysis. And you input the age and sex and some other numbers and stuff, and it pulls out a number for you. So for my patient, this 84-year-old woman with a GFR of 45 and no proteinuria, her risk of progressing to end-stage renal disease and needing dialysis is exceedingly low. So I don't quote these numbers to the patients, but I use them to sort of back up my gestalt that, chances are things will be just fine. And that's true for her if nothing else happens. But if nothing else happened, we would be done, and I'm going to talk for another half hour, so something's going to happen. So a lot of questions arise with this. I showed you that graph from the CDC that a large percentage of older folks have CKD. So questions have arisen about this. Will the diagnosis and treatment of early chronic kidney disease in older patients confer any benefit whatsoever in terms of survival, cardiovascular disease, chronic kidney disease? And do the benefits outweigh the harms of diagnosis and treatment? And Dr. Moynihan and colleagues have written a lot about this. They've written that overdiagnosis and related overtreatment are major problems, and you all know this. We've heard a lot about this recently. For instance, it's come up with early breast cancer screening, for example. They also point out that even where there are prospective randomized controlled trials, positive results from treatment trials can mask situations where patients at low risk may receive no benefit. It's kind of a fancy way of saying that the patients who are in the trial may or may not, well, they're usually not, reflective of the entire universe of patients. And there was an interesting analysis that was published looking at exactly that question related to patients with chronic kidney disease. As you probably know, ACE inhibitors and angiotensin receptor blockers have been shown to slow the progression of chronic kidney disease in a number of conditions such as diabetes. And so they decided to look at how they could look at these treatment effects from the clinical trials in the context of real-world risk information. And specifically, they wanted to ask the question, okay, we know that these drugs are great for slowing the progression of kidney disease in these clinical trials. Is that true in older patients that we see in real life? So these are from some of those clinical trials, and these are famous trials, a couple of diabetes trials, et cetera, where they looked at the role of the effect of ACEs and ARBs in slowing the progression of kidney disease, and they were very effective. So the number needed to treat, how many patients do you need to treat with an ACE inhibitor to prevent somebody from going on dialysis? These numbers are very low, and I think everyone would agree that this is pretty powerful evidence that you should consider putting your patients on it. So they said, okay, but these were clinical trials, with age limits and all kinds of selection and exclusion criteria and stuff. What about the real world? So they looked at a VA population. They identified about 790,000 veterans over the age of 70. They looked for those who had either chronic kidney disease or proteinuria and found about 371,000. So this is the VA population. The mean age was 78. They were mostly male, minority African American. The mean GFR was 48, which is pretty close to what my patient was. And most of them didn't have any proteinuria. So what they found in this group is, first of all, very few actually went on to need dialysis within 3 years. There was a range there. The lowest risk group, which is not very advanced kidney disease, no proteinuria, like my patient, was almost nothing. The highest risk group were those with more advanced chronic kidney disease and proteinuria. The number needed to treat to have a 30% reduction in the relative risk of needing dialysis ranged from 16 in the highest risk group to 2,500. And in fact, 91% of the cohort belonged to a group for which the number needed to treat was greater than 100. That's a long way of saying you're not going to benefit very many patients by doing this. And the take-home message, I think, is very important, is most older patients with chronic kidney disease do not need ACEs and ARBs. So I see a lot of patients who have chronic kidney disease and have been placed on one of those drugs by their PCP, being aware that these drugs can be renal protective. But when I look more closely at that patient, there's no proteinuria, and furthermore, the patient keeps getting episodes of acute renal failure because they get dehydrated and they're on the ACE inhibitor. So think about it. You not only don't need to start the drugs, but I actually spend a lot of my time taking these patients off the drugs don't need it. Not going to benefit. They also excuse me, point out that evaluation of diagnostic tests usually looks at how well they detect the presence or absence of disease, but not how well they detect clinically meaningful stages of disease. Changes to disease definitions often do not involve the evaluation of potential harms of overdiagnosis, stress, unnecessary testing, et cetera, et cetera. And oh, by the way, sometimes these are conducted by heavily conflicted panels. So they referred to another study, which I thought was terrific. So instead of talking about the number needed to treat, let's talk about the number needed to harm. So a possible solution would be to separate adverse effects into different grades. Number needed to kill. This is, say it, just say it there. Number needed to disable, number needed to make you ill, and number needed to annoy. And the concept of attaching a price list to the therapeutic agent should not stop at the cost of the pill. So I think that was a clever way to put it. But the question is, you know, we need to think about potential harms. The same authors have written that they think that with chronic kidney disease, expanding these definitions, and they do change the definitions about every 4 years, are unnecessarily labeling many people as disease. Why is a GFR less than 60 considered abnormal for everybody? I mean, I agree, it's definitely abnormal for a 40-year-old, but for an 80-year-old, no. 3/4 of the patients with CKD3A, which is very, early kidney disease, don't have any proteinuria. And we know that presence or absence of proteinuria is an important prognostic sign. So they're wondering if this is really a disease or medicalization of the normal aging process. I wonder that too, and I think that's something we need to settle. I certainly get a lot of consults on these patients, and the good news is I can usually just dispense reassurance. So, okay, so my patient gets some hip pain, for which she takes some Aleve. And then she's seen by her primary care provider, and now her creatinine is up to 2.2. So why is that? Well, this is a beautiful paper that was published back in 2007, kind of explaining the concept of normotensive ischemic acute renal failure. In other words, you don't need to be hypotensive to get ischemic acute renal failure. And Dr. Abuela made the point that a normal autoregulation curve looks something like this. So the kidney has a great ability to auto-regulate its renal blood flow as systemic blood pressure falls. So in a normal patient, blood pressure can fall going from right to left to some point at which it can't auto-regulate anymore and GFR just kind of starts to plummet. But there are some patients who cannot auto-regulate that well. So at a higher level of blood pressure, they lose renal function. And sometimes, we see this sometimes in patients where, where it can be a normal range. There was a patient who normally runs a systolic blood pressure of 150 to 160. That's normal for them. Their kidneys are accustomed to that. Sometimes if it comes down to 120, that's enough to make the GFR fall off the cliff. So why does that happen? So these were some beautiful diagrams that were in that same article, and I'll explain it to you. So the glomerular capillary network is unique in the body in that it sits between two resistance vessels, the afferent and efferent arterioles. And these things can modify their tone at a moment's notice to sort of adjust for changes in systemic blood pressure and renal blood flow. So so the afferent arteriole determines how much blood of the blood pressure is transmitted into the glomerular capillary network. Efferent arteriole is kind of a downstream pressure valve. So what happens when your blood pressure starts to fall for any reason, you're having an MI, you're having a GI bleed, it doesn't matter, your blood pressure is going down, the kidney figures that out and it wants to auto-regulate. So the first thing it does is it dilates the afferent arteriole, opens up the afferent arteriole to get as much blood in as possible. And that's under the influence of vasodilatory prostaglandins. Then as blood pressure falls further, you constrict the efferent arteriole in an attempt to maintain your glomerular capillary pressure. So you can start to guess where I'm going with this. If you're on a non-steroidal, that those block prostaglandins, you cannot dilate the afferent arteriole. So basically, you cannot autoregulate. And it's even worse if you're also on an ACE inhibitor because you can't constrict the efferent arteriole. So for a patient who is on both of those drugs, especially a patient who may have some pre-existing, small intrarenal vascular disease, like most of us older folks, it doesn't take much to produce acute renal failure. And there's lots of reasons that older people are susceptible to acute kidney injury. This is from a consensus conference we did at the NIH a few years ago. I've mentioned we've got age-related functional changes. GFR is already low. There's structural changes in the vessels and the tubular interstitial fibrosis. There's chronic comorbidities, especially cardiovascular disease, and all the stuff we do to patients. We give them ACEs and ARBs and nonsteroidals and contrast and all that. There's issues with stress-induced cellular senescence, acute and chronic inflammation, and of course, oxidative stress. So basically, that's a way of saying that the older kidney is less able to withstand insults and more susceptible to acute renal failure. You all know that, right? If you look at the data, it's just going up and up. So what is her prognosis? Okay, my patient had acute renal failure. We stopped her drugs. Her creatinine got a little better, but not to her baseline. So there are a number of things that factors you can consider when you're trying to determine what a patient's chances are of recovering and what's going to happen to them. As a nephrologist, I get this question all the time. Patients dialyzing in the ICU, the family wants to know, are the kidneys going to get better? Well, you never know for sure, but there are a number of disease modifiers that we've identified that can help us figure out what the chances are of renal recovery. One is the severity of acute kidney injury. If you have acute renal failure bad enough to require dialysis, even if it's not for very long, your chances of going on to more advanced kidney disease are extremely high. The stage of chronic kidney disease, if you start with pretty advanced kidney disease, knock off a few more nephrons with acute renal failure, prognosis not so good. The number of episodes, and I'll show you a graph of that in a minute, but we know that patients who have repeated episodes of acute renal failure, either because they have recurrent GI bleeds or they're cardiorenal or something, that's a risk factor for sort of going on to have more advanced chronic kidney disease, the duration of the episode, and of course, proteinuria. So this is sort of a graphic illustration. This is a patient that I saw a few years ago who had cardiorenal syndrome. So she was one of those patients who would get volume overloaded and her GFR would fall because she's not perfusing her kidneys. And then she'd come in and get over-diuresed, and then her GFR would fall again because she was volume depleted. And it would just go on this cycle. And when I see this kind of sawtooth pattern, it always sounds like cardiorenal to me. But if you look at what happened, this is just a 3-month period. Her creatinine started at about 1.2. Something happened, it went up to 1.5, sort of came back to baseline. The next time it went up to 3.2 and kind of came back to baseline. The next time it went up to 4.5, and the next time it went up to 7, et cetera. And so at this point, we can sort of see that she is, first of all, never going to be down at 1.3 again, and the curve is, the trajectory is ominous for loss of renal function. So kind of a really graphic example of the concept that multiple episodes of acute renal failure have a bad renal prognosis. Okay, so I thought I already said this, but I didn't. The ACEs and ARBs are stopped. Her serum creatinine settles at 1.8, GFR of 22. So not back to her baseline, but better than it had been. So she is referred to a nephrologist. So she's now stage 4 CKD, and that's a very appropriate time. We like to see the patients when they're that far. And a brief discussion introduces the topic of dialysis with plans to further explore the goals of care in subsequent visits. This happens all the time. I do this all the time. So one of the tenets of the Choosing Wisely campaign was this one, which makes a lot of sense. Don't initiate chronic dialysis without ensuring a shared decision-making process between patients, their families, and their physicians. And duh, you say. Well, of course it's a shared decision-making process, but it's a complicated one, and it doesn't always get done well. Talking about dialysis is like talking about cancer. Trust me, I do this for a living, so I can tell you this. Patients and families would prefer not to think about it and wish it would go away. Providers would prefer not to talk about it. We'll talk about it next time. The discussions are difficult, but we know that the patients want the information. They expect their physicians to initiate the conversation. I shouldn't just sit around and wait for the patient to say, well, what about dialysis? That's on me. And they want to know their options, but it's complicated. This was a nice paper, looking at the interdisciplinary care of older patients and ask the question, whose job is it anyway? Is it the primary care provider's job to do this? Is it my job? I don't know. The issues are there's complex and fragmented medical care, and whether you're on the specialist side of the fence or the primary care side of the fence, you all know exactly what I'm talking about. Lack of shared understanding and vision, unclear locus of responsibility, and lack of active collaboration and communication. In fact, we don't do a very good job of this. This was another study that looked at the barriers to adequate preparation of patients for dialysis, right? Poor integration of care, patients' low perceived urgency for dialysis preparation. And I kind of get that. When I'm talking to patients, I think sometimes as soon as they say, we don't need to do anything right now, they just kind of say, okay, good, denial. We'll think about it later. Patients are understandably afraid of dialysis. There's issues with cultural beliefs, language barriers, lack of trust, and variations in provider insight. So that's a long way of saying we don't do a really great job of establishing goals of care, especially with respect to dialysis, in our patients. Subsequent discussions are inconclusive. This happens to me all the time. So over the next year, her renal function declines to stage 5, and it really is time to make a decision, right? We can't put this off anymore. But what is the decision? So people are starting to question the ethics of dialyzing older people, especially frail older people with comorbidities. We all know that there are some older folks who are doing great, others not so much. So, and these papers started coming out, dialysis in the frail elderly, a current ethical problem and impending crisis, the ethics of chronic dialysis, practice changes needed for dialysis decision making. And the underlying, and I'll talk more about this, but the point is that just because we have dialysis doesn't mean it's the right thing to do. So when you think about the overall goals of care for a patient, are usually things like they would like to be cured, would like to live longer, improve or at least maintain their function and quality of life, be comfortable, achieve life goals, et cetera. Dialysis isn't going to do any of this for most of these patients, right? So yes, it might prolong your life, but it's not going to necessarily contribute to achieving these goals of care. Again, especially in the frail older patient with multiple morbidities. So how do we do about that? The same group that did some of those earlier studies looked at, okay, so what do we do with dialysis decisions in older patients? And they again used the VA population and did a retrospective analysis of about 29,000 veterans with a GFR less than 15, right? That's stage 5, time to talk about it. And so they looked to see how many patients had decided not to do dialysis. So less than 65 was the reference group. 65 to 74, twice as many had decided, nah, I don't want to do dialysis, which makes some sense. And over 75, almost 6 times as many patients said, no, I'm not going to do dialysis. That makes sense to me. But then what do? We dialyzed them, right? So if you look at this, this is ages less than 45 on the right, over 85 on the far right. And look at these bars here. So 75 to 84, 75 to 79, 80 to 84, and over 85. In the 75 to 79 group, 60% of the patients were getting dialysis. And even in the over 85, over 30% were getting dialysis. I'm not saying that's the wrong thing. It's just kind of surprising that there are that many robust over 85-year-olds that one would think is a good candidate. And we're different from other countries. So the same study looked at, okay, so what do they do in Canada? So in the U.S. is in black, Canada's in gray, Australia, New Zealand are in white. Those are populations that sort of look like us, and the countries can afford dialysis and all that kind of stuff. Very different. If you look at the 75 to 84-year-olds, we're dialyzing 2/3 of them, much lower number in those other countries, and over 85, a big difference. So not saying this is right or wrong, but it's interesting. I'll tell you a little bit more about it. We also know that once a patient is frail enough to be in a nursing home, they will do terrible on dialysis. And this is really kind of a horrifying study where they looked at, for a 2-year period, looked at every single U.S. nursing home resident who started dialysis. And they looked to see what happened. So this is months after dialysis. After 3 months, about a quarter of them had died. About a third or so had decreased functional status, and about 40% maintained functional status. At 6 months, half of them had passed away. At 9 months, over 60%. And by a year, 3/4 of the patients had passed away, and almost nobody was maintaining functional status. In other words, the long-term prospects for a healthy, fulfilling life in a patient who's already in a nursing home starting dialysis, they're just not great. Furthermore, and this is on us as a nephrologist, I think our care of these patients, dialysis patients, in the last month of life is terrible. So this one looked at how what we do with dialysis patients in their last month of life as compared to cancer patients, which is in the middle here, and heart failure patients. So unfortunately, our dialysis patients are much more likely to be in the hospital in their final month of life, spend almost a third of that month in the hospital. Half of them spend time in an ICU, and almost none of them are on hospice, a very low number, and half of them die in a hospital. So that's really not great end-of-life care. And again, that's on us, but it is what it is. So if I decide to put my patient on dialysis, what's her prognosis? So this is back to that QXMD app, and it actually has a little algorithm to help you estimate how long is your patient going to survive. If I take this patient, any age, and start dialysis today, what are their chances of surviving 6 months on dialysis? And my favorite question, it's got age, albumin, dementia, stuff like that, is the surprise question. Would I be surprised if this patient died in the next year? And this question has actually been validated, and the geriatricians in the audience may be aware of this. But it's kind of useful, and you can do it. And I actually use this. I don't say to my patients, you have a 78% chance of dying in the first 6 months, but I use it to sort of back up my gestalt that, dialysis may not be the best thing for you. So what happens if we don't start dialysis? There's a lot of interest in now, and there's a whole new sort of subfield of supportive care nephrology coming out, recognizing that, we can do a lot of things for our patients other than putting them on dialysis. So this was a prospective observational study of 395 older patients. Those who said, nah, I don't want dialysis, I'm not going to do it. Those who chose not to have dialysis survived a median of 16 months. A third of them survived a year past the time that somebody would have otherwise put them on a dialysis machine. And in fact, survival may be comparable when you subtract all the dialysis days and hospital days. How many good days do they have left? Maybe the same whether you do or don't choose dialysis. These are the things that we need to think about, and that I need to think about and talk to my patients about. Again, so it's really, as best we can, an informed decision by the patient and the family. So what happens at the end of life? This, I thought, was an interesting graph that was produced by Jean Hawley, who's a geriatric nephrology trained person. So sort of looked at the trajectories for a number of clinical conditions, functional ability over time. So if you have colon cancer, for example, many patients will do really well for a while and then not. If you have heart failure or COPD or you're a dialysis patient, you're going to kind of dwindle over time, and you're going to have exacerbations where things get a little worse and they get a little better, but over time go down. If patients have frailty and dementia, they start at a much lower functional ability and then kind of just keep going down. But if you have advanced chronic kidney disease and don't take dialysis, you can actually do pretty well. These patients can maintain very reasonable quality of life and functional ability for quite a while, and then, of course, succumb. So there's more challenges. So far I've been talking about the leisurely discussions of goals of care that we hopefully are having in clinic while we're sort of helping patients work through to dialyze or not. But it doesn't always happen that way. So this deliberate process of shared decision making is the goal. But it turns out that more than half of all dialysis patients start dialysis during a hospitalization. And if they haven't already made a decision about dialysis, it gets complicated. Because while they're in the hospital, they're often acutely ill, vulnerable. There's cognitive issues that occur with being in a hospital. And there's momentum and pressure from various sources, including other specialties, to do something, right? So it's kind of hard to do what we would all recognize as ideal shared decision making. So my patient, guess what? She's admitted to the MICU with pneumonia, sepsis, and oligoanuric acute kidney failure. The MICU team tells the patient and family she needs dialysis. We'll call nephrology. Don't do that. We hate that. You're setting me up to come in and have that goals of care discussion you should have had. But trust me, this happens all the time. So what will be the outcome if we dialyze her? Well, not very good. And just generally, you all know that older, frail patients who are in the ICU just in general don't have a great prognosis anyway. This was just one of many studies showing that among older patients with critical illness, and this is not even addressing dialysis, more than half died within a month or experienced significant functional decline over the following year, with particularly poor outcomes of those who had high levels of premorbid disability. And these observations should inform our discussions about prognosis and goals of care during critical illness. And again, this is even without the dialysis question. So that's raising the question of the ethics of offering dialysis for acute renal failure, right? I told you before, people were wondering about the ethics of dialyzing frail older people chronically. What about acutely? And these authors comment that a major consequence of the biomedicalization of aging is the relatively unquestioned provision of dialysis for acute renal failure to older patients. We have it, so we should do it. They say nephrologists should not automatically recommend dialysis for older patients. And those who can be predicted to do poorly, as per that study I just showed you, recommending against dialysis actually upholds the Hippocratic maxim to be of benefit and do no harm. So they challenge the automatic transformation of the technological imperative into the moral imperative for these patients, hence the title of this talk. So with my patient, it all works out after discussions among the patient, the family, the treatment teams, palliative care. They're essential in this process. She was transitioned to comfort care and passed away peacefully. So there are many other issues that sort of come into this, and one is this, the fact that as a country, we are somewhere in the shift from volume-based care to value-based care. Right now, we're pretty much still in the fee-for-service world, and I certainly am. And as a practical matter, if we dialyze this patient, I get paid more, and the hospital absolutely gets paid more. So, for nephrologists in private practice, outpatient dialysis is a huge chunk of their income, right? So there's a financial incentive that right now cannot be ignored. I'm just going to say that. I would hope that as we complete the transformation, which I'm convinced is going to occur, to value-based care, then it will be, there won't be such a disincentive to withhold dialysis from a patient who really shouldn't have it. I will just say that. And I'm not going to rant and rave more about this. I'll let John Oliver do it. The financial incentives are horrible for dialysis. And John Oliver had a great segment, which you can just Google it and find it, sort of where he rants and raves about the perverse incentives of a large for-profit dialysis unit. This is the world we live in. I'm really hoping to still be around by the time that we get to a more, what I think is a more sensible world. And I don't want to completely trash the large dialysis units because they do amazing things. And then there's these really sort of heartwarming stories of when there's a natural disaster and, you know, patients can't, their ride can't come pick them up for dialysis and stuff. The dialysis units do a wonderful job. They stay open 24/7. They just get them all in. So they're not all bad. It's the financial system, which, in my opinion, could use some work. Take home, I always need to put this in here for the primary care providers. In fact, all non-nephrologists, it's your job to pick up kidney disease because by the time the patients get to me, it's often too late to do much of anything except try and have a goals of care discussion. So primary care providers and non-nephrologists have a very important role in the early diagnosis and treatment and patient education. The good news is, and I tell this to my patients, is that what we need to do to protect your kidneys is common sense. The same stuff that's good for your heart is good for your kidneys. You need to control your glucose, your blood pressure, your lipids. You need to stop smoking. You need to stop taking non-steroidals. So that's a pretty simple message that hopefully everyone can remember. And if you're having goals of care discussion with older patients with advanced chronic kidney disease, please ask about dialysis. I can't tell you how many consults I get where an 85-year-old has a creatinine of 4 and I can't find the word dialysis anywhere in the chart. It's not on post forms. I personally have an advanced directive form. It doesn't say anything about dialysis, so I guess maybe it's a little early for me to be thinking about that. But just please, when you're having these discussions with your patients, ask about dialysis if their creatinine's 3 or 4, because it's going to come up. Remember, first, do no harm. And I will end you with this. I love this picture. This is by Jose Perez, which is called A Day in the Hospital. And I think it kind of very beautifully depicts the chaos we live in. So I will thank you for your attention. I'm very happy to take questions. Say that again. I'm sorry, I didn't quite get it.
You showed a difference in what percentage go to dialysis after 85 in Canada and Australia. Is that part of their healthcare system legislated for them?
Yeah, so the question is, in Canada and Australia, is it part of the healthcare system that basically older people are not allowed to have dialysis? And that is not true anymore. It was, actually when we started doing dialysis in this country, it was rationed, right? Because there weren't very many dialysis units. Was very famous that in the UK there was an age cutoff and stuff. That's not true anymore. So Canada and Australia have the same approach that we do, that if a patient wants it and if they're a viable candidate, they can have it. So that doesn't explain it. What I think it is, unfortunately, is it's really hard to help the patient do truly informed consent, right? There's a hope. Nobody wants to die, right? So if a patient understands that dialysis will or might keep me alive longer, even with the inconvenience of going to a dialysis unit all the time, if you put that against fear of dying, patients want to do it. But I think it's our job to make them understand that dialysis is not a panacea, right? It's not. You're not necessarily going to benefit that much. So I think that I just wonder if they don't do a better job with those discussions than we do.
In your slide about kidney injury and prognosis, episodes of dialysis was a risk factor. Is that, do you think the dialysis doing something, or is it a marker of bad enough injury you need dialysis?
Yeah.
Is dialysis
So-
really harmful for some people?
So the question is, if an episode of dialysis requiring acute kidney injury increases your risk of chronic disease, is the dialysis doing something bad? I don't think so. I think it's just my simplistic thinking is you just knocked off more nephrons, right? I think well, it's an interesting question. I don't know if anyone's ever studied it, but I don't think that dialysis per se is likely the cause of subsequent disease so much as just being reflective of how bad the damage was. We'll see. Does it make sense to stop lisinopril if you prescribe an NSAID? Yes, please. The combination puts anybody at risk. It's less likely to put a young, healthy person who's well hydrated at risk. It's really going to put an older person at risk. So I would be happy to do that. I preach against nonsteroidals every visit, and I ask my patient every visit, and I say, so just want to make sure you're not taking Advil, Motrin, Aleve, all that kind of stuff. Just had a patient I've been following for a while who admitted he was taking Celebrex and didn't know that was an NSAID. Celebrex, who uses that? So I think you need to consider the risk, because there's risk for acute renal failure and there's risk for hyperkalemia too, right? The two of those together really does it. So I would think about that. Yeah.
Does it matter if you separate those two drugs in the morning dose and the evening dose?
Oh, interesting question.
Is that in there or not?
Does it matter if you separate the morning and evening dose? I guess it could. The ACE inhibitors and ARBs are long-acting drugs, so they're kind of 24-hour drugs. If you take a short-acting Motrin, what a great question, never thought of that. 12 hours separately, not Aleve, but a Motrin, that might help. I don't think that's ever been studied. I think it's better to be careful. I think the thing is to look and see, does the patient really need the ACE inhibitor? Because I see patients, they don't have any proteinuria, they don't have heart failure. There's no indication for the ACE inhibitor. They've got hypertension, but we've got 20 other drugs we can use for that. So I think that it's safest to stop it, but if you can't, that's an interesting approach. Could try it, I guess. Hadn't thought about that.
Do you have any concern about the new, more rigorous guidelines for systolic blood pressure control in the elderly?
I wish I hadn't asked that. Question is, what about the new guidelines for systolic hypertension in the elderly? I've given up on the guidelines because they change. The guidelines fluctuate just like that patient's creatinine did. I'm old-fashioned. I think that for a young, healthy, vigorous person, pushing the blood pressure down, especially with kidney disease, pushing blood pressure down below 130 is absolutely worth trying. Older people, I just worry that they're going to get dizzy and fall down and break their hip. And I know people will say, no, there's literature that doesn't happen. Oh, come on. Sure it does. So there is evidence from the HIVET study several years ago now that, in patients so nobody should have uncontrolled hypertension. And in older people over 80, getting the blood pressure down below 150 over 80 offers protection. Would there be a little more if you push lower? Maybe. But that's a long way of saying I don't push too hard. I'm not sure what the gain is going to be. Certainly in terms of, for preventing the progression of kidney disease, my patient had no risk essentially of going on to dialysis anyway. And no matter what her blood pressure is, if she gets pneumonia and has to go to the ICU, it's not going to matter what her blood pressure was. So I'm kind of nihilistic about that, but that's probably politically incorrect. Yeah. Yeah, no, so the question is, are ARBs any safer than ACE inhibitors? The answer is no. They're equivalent for that. So Liz Stevens can argue with me now. So the guidelines have said for a long time that indications for ACE or ARB include proteinuria or diabetes. So diabetes without any proteinuria, I've always been not so sure about that. Microalbuminuria, yes, there is evidence that it's a good idea, but again, in an individual patient, you've got to risk benefits and harms. If the patient keeps coming in with hyperkalemia and I've already tried to change their diet and I mean, at some point you got to say enough already. So more advanced proteinuria, yeah. But to answer your question, ACEs and ARBs, consider them equivalent. The only difference is that patients on angiotensin receptor blockers are less likely to cough. Way in the back. Sorry. Treating I was thinking hypothyroidism. No, hyperparathyroidism. So, yeah, that's another one. As a nephrologist, I screen all my patients for the vitamin D and PTH levels, right? And the PTH levels are generally high. We know that that's secondary hyperparathyroidism. The guidelines, I mean, they're even worse on the blood pressure guidelines. So there were no guidelines, and then Kadoki came out with this, if the GFR is stage 3, you need to keep it between 30 and 70, and for stage 4, between 70 and 110 for PTH levels. And they said, but of course that's all opinion-based, there's no data. And then KDIGO came out and said, there really isn't any data, so we kind of don't know. So that gives me carte blanche to do whatever I want. So what I do, I do believe that a very high PTH is a bad thing, and you're going to be at risk for, bone disease and all those things. So I think every nephrologist kind of chooses a range that he or she is comfortable with and hopes the patient is too. So for me, if the PTH is under 120 in a patient with chronic kidney disease, I don't care. I mean, I say that's fine. Once it goes above that, then I start treating them, and the drug to use, first of all, make sure they're vitamin D replete. That's the first thing. And then the next drug is calcitriol. My clinic's in the VA, so I'm lucky, so I don't have to worry about cost or who's going to pay for it. It's not a cheap drug. So is that what you were getting at? Yeah. Well, calcitriol is not that expensive. I mean, it's cheaper than vitamin D. Some of the other ones, they're not any better than calcitriol. So I think that, the goal PTH range for, I don't do chronic dialysis now anymore, but, the levels were sort of 250 to 500, we sort of accept higher levels. So I would, calcitriol, like I say, it's not dirt cheap, but it's not $1,000 a month either, so. Mm-hmm.
Yesterday, I ran into a family of a former patient who has Down syndrome. He was 20 years old, and he said he's just getting ready to start dialysis.
Wow.
And I said, just curiosity, they talked about renal transplant. Well, they've already identified a donor. What's your experience with Down's patients in this moral setting of do you dialyze?
Wow. So my experience with Down patients requiring dialysis is 0. I mean, doesn't mean it doesn't happen. The good news is it means that Down syndrome is not a risk factor for needing dialysis. So for this patient, something else happened. So if I were meeting this patient, my evaluation process would be the same as it is for any other patient. Is this a good patient, a good candidate for dialysis? Would the patient tolerate it, and would the patient benefit? A 20-year-old, yeah, would certainly, in terms of longevity, would benefit. Being evaluated for a transplant, that's terrific. I mean, sometimes I have patients, who are 50 years old and have, cirrhosis and dementia and, 17 other things, and I feel just as reluctant to put them on dialysis as a frail older person, partly because the patient's not going to understand it, not going to tolerate it, so it's different. So that's a heartwarming story that they're considering a transplant patient for that Down patient. I've never seen one. Yeah, well, I don't know. I mean, end-stage renal disease in a young person, a common issue is reflux, if they had congenital reflux. I mean, we sometimes see kids going on dialysis and needing a transplant when they're 4 years old, you know, I mean, so that can do it. Or I guess any kid could have got glomerulonephritis, I guess anything, all kinds of things could happen. Interesting. Yeah.
How does that, Led, for what you say about overtreating systolic pressure in older people, how does a wide pulse pressure enter into your thinking when you're treating hypertension?
Yeah, so I kind of need to defer to the cardiologist because I think I think the thinking on that sort of varies as well. Those are the hardest patients to treat, of course, right? You know, the patient is 160 over 40, you know, because at some point you're not going to be able to get that systolic down without doing other things. So I tend to really not be too aggressive with those patients, and that may be the wrong thing to do. So good question for a cardiologist who will say something different, I'm sure. Yeah.
Elderly patient, you start an ACE inhibitor, there's some bump in their creatinine. How do you judge what is too much of a bump and given what underlying other health factors?
Yeah, that's a good question. I'd say for an elderly patient or any patient, if they get a bump in their creatinine, how much is too much and when do you worry? So it is said, and this is sort of a reasonable thing, if the creatinine increases by 30% over wherever it started over a period of weeks, days to weeks, that's probably okay. If it goes up more than 50% really soon, within a day or two, that's not okay. So it's kind of a function of sort of how much of a bump. You absolutely have to keep an eye on it. And sometimes, you know, we know that a little bit of a bump, you may be seeing something good. You may be reducing glomerular capillary pressure. So if it bumps a little bit, I don't freak out and pull the drug back, but I make sure and check it again in a few days to a week or something to see how it is. A related question on which there's no consensus is if a patient has chronic kidney disease that's progressing and has been on an ACE inhibitor for a long time, at what point do you say it's time to stop? So and that's also variable. I have some colleagues who never stop it, which I think is brave. My feeling is if a patient has a GFR of 12 and they're on an ACE inhibitor and then they take a non-steroidal, they've got no protection. But on the other hand, if the patient's GFR has just been slowly changing and they do have other indications like proteinuria and heart failure, sometimes they don't stop it, but then the creatinine starts to go like this, and then I stop it. So there's no consensus on when or whether to stop an ACE inhibitor in a patient who has slowly progressive chronic kidney disease. By that point, however, the patient should be being followed by a nephrologist, so you can let us try and sort that out. Okay, thank you.